Welcome to the Schwarzman Animal Medical Center's 10th annual One Health Conference, hosted by the Ann and Charles Johnson One Health Institute. My name is Heather Ashcraft, Senior Veterinarian in Radiation Oncology at AMC, and I will be moderating tonight's event. This is a day 3 of our conference where we are exploring a comparative approach to cancer diagnosis and treatment. After tonight's talk, we will take questions from the audience, which can be submitted through the chat box. And as a reminder, at the end of the event, please click the link in the chat or scan the QR code to submit your form for CE credit. Tonight, we will be discussing the comparative oncology and translational aspects of meningiomas in human and veterinary patients. I'd like to thank both of our speakers, Dr. Kathryn Beal and Dr. Rachel St-Vincent, for joining us tonight. Dr. Rachel St-Vincent received her doctorate in veterinary medicine from the University of Montreal and completed a one-year internship program in small animal medicine and surgery at Washington State University. She completed a residency program in veterinary radiology and earned a Master of Science degree at Western College of Veterinary Medicine at the University of Saskatchewan in Saskatoon, Canada. She did her clinical training in radiation oncology at the Animal Cancer Treatment Center and William Beaumont Teaching Hospital in Michigan. Dr. Kathryn Beal is a board-certified radiation oncologist at New York Presbyterian Hospital, Weill Cornell Medical Center. Dr. Beal received her BA from Harvard College, then received her medical degree from the College of Physicians and Surgeons at Columbia University, and completed her residency in radiation oncology at Memorial Sloan Kettering Cancer Center, where she was also elected chief resident. Following residency, Dr. Beal was the director of the Brain Tumor Program in the Department of Radiation Oncology at MSKCC. She was involved with a number of treatment protocols of radiation therapy for brain tumors, as well as imaging of brain tumors as related to radiation therapy planning and treatment response. She was awarded an R21 grant to investigate the use of 18F fluorocholine to distinguish necrosis from recurrence in brain metastases. She personally treated 200 brain metastases patients per year with stereotactic radiosurgery and managed these patients long-term. Dr. Beal has published and presented several original studies that demonstrate a change in response and improved outcome in patients treated with the combination of SRS and immunotherapy, and has become a leader in this emerging field. Thank you, Dr. Beal and Dr. St-Vincent. We look forward to hearing your talk tonight.
Thank you, Heather. Hello, everybody, and thank you for coming tonight. My name is Rachel St-Vincent, and I am head of radiation oncology at the Animal Medical Center. Tonight, I will go over general similarities and differences of meningioma tumors in cats, dogs, and humans, challenges and focuses for the future of our companion friends. Embryologically, meningeal layers are derived from mesenchymal cells that surround the neural tube during development. The layers consist mostly of fibroblasts, which appear to be molecularly distinct from one another based on the layers that they are localized in. The meninges are made up of 3 distinct layers, you can see here, that together play an important role in protecting the central nervous system. The most superficial layer, the dura, is intimately associated with the periosteum of the skull and vertebrae, and mostly made up of fibroblasts. The arachnoid layer is the layer that holds the cerebrospinal fluid, or CSF. The most superficial layer is made up of specialized epithelial-like cells, which are also called meningoepithelial cells. The cells forming the first layer opposed to the dura are specifically called barrier cells, and these are heavily loaded with tight junctions sealing the cells firmly together. These cells are in continuation with multiple web-like fibrous extensions lined by fibroblasts, which extend deeper in continuation with the last layer of fibroblastic cells that line the cerebrum, which is also called the pia cell right here. Sorry, this is the pia, this is the arachnoid. From the barrier cell layer, there are multiple invaginations penetrating into the dura and in the venous system of the dura, including the venous sinus. Very specialized meningothelial cells forming a cap over the tip of villi right here are also called arachnoid cap cells. And the transformation of these cap cells is what leads to development of meningioma. The common occurrence of meningiomas at sites with a higher density of arachnoid villi supports their association with these structures. The grading system for meningiomas include three categories referred to benign, atypical, and malignant or anaplastic. Many histologic types exist in meningiomas, which does appear to influence the biological behavior of tumors in human meningiomas. This is therefore taken into consideration when grading humans, which we can see listed right here, where these include meningothelial, fibrous, transitional, pseudomatous, angiomatous, secretory, microcystic, lymphoplasmacytic, and metaplastic in the group, grade 1 group. Atypical, clear cell, choroid, and rhabdoid subtypes are included in grade 2 categories. And this has been changed just recently in 2021, whereas all anaplastic meningiomas are automatically considered malignant and they belong in, that third category for all species. Oops. Sorry. Okay. Unfortunately, subtypes consistently show no correlation to outcome in dog studies, and therefore this has been removed from the recently updated canine grading system, which was published in 2023, with, of course, the exception of those having anaplastic features, which still automatically fall into the category 3. In addition to subtype grading features, the mitotic count is also a very important grading criteria, which we see is very similar in all species. The mitotic count is set to the same cutoff level in a cat and humans. However, recently in the 2023, an updated standardization was established in the grading system of canine, changing the mitotic cutoff to a slightly higher value of 6. This moved a fair amount of diagnosed patients from the grade 2 category to grade 1, and also can potentially move patients with high mitotic count of 20 from the grade 3 to the grade 2 category. Outside of the subtypes, another histologic feature that places tumors in category 2 or the atypical is the presence of invasion. Or we can see here at least 3 of the following structural criteria, which includes hypercellularity, presence of small cells with an elevated nuclear to cytoplasmic ratio, presence of macronucleoli, sheeting architecture, and spontaneous foci of necrosis. Other than the presence of significant anaplasia, recent additions that are now considered grade 3 features in human grading is also the presence of the TERT promoter mutation, which stands for telomerase reverse transcriptase, as well as the homozygous deletion of the CDKN2A as well as 2B. Yeah. More studies on these two genetic alterations is first needed to determine their relevance and whether they should be added in the grading system in cats and dogs, and there's really not much in the literature about that yet. Lastly, although the updated classification criteria has changed significantly in the canine system, this has led to a higher inter-observer agreement in grading of these meningiomas, which is great, but a close look is still needed to see if this new grading system does in fact correlate well with the anticipated tumor behavior in the clinical setting. Meningiomas have a very high tendency of being benign, both in the cats and the humans, with higher number of tumors behaving atypically in dogs. So approximately 80 to 90% of these tumors are benign in cats and humans, but only approximately 50% are classified as benign in the dogs, which is leading to a significantly shorter survival time in this species in particular. One classic characteristic of benign meningiomas include slow growth. This often allows gradual adaptation to the environment change in the brain and thus delays and often leads to only subtle symptoms that are noticed by owners at first. These symptoms are often initially attributed to normal aging of patients, particularly because they most often occur in geriatric older patients. As such, by the time they do induce more obvious clinical symptoms, these tumors tend to be quite large in size in our patients. One diagnostic imaging study found that meningiomas often occupy as much as 10 to 15% of the entire cranial cavity volume in the cat population, as compared to 4 to 8% in the dog population. Symptoms can vary a lot and often depend on tumor location, but they can also result from intracranial hypertension caused by compression on the surrounding vasculature and the ventricular system, leading to cerebral hypoperfusion, vasogenic edema, and often brain herniation. The most commonly reported symptom in the dog tends to be seizures, which is seen in approximately 90% of them, whereas in a cat, mentation changes is the most common reported symptom. Another very interesting phenomenon occasionally seen is the presence of multifocal tumors. This has been reported in humans as well as our veterinary companions, but is most common in the cat with a frequency of 10 to 17%, whereas it is only seen in about 1 to 2% of dogs. Multifocal meningiomas are thought to be most likely stemming from multicentric dural foci due to their benign nature and the fact that these often are reported to show tumors of two histologic subtypes in the same patient, therefore making it less likely a result of CSF or vascular metastasis. These tumors are more common in women compared to men in humans, with a higher incidence in African Americans. And approximately 1% of meningiomas are associated by the neurofibromatosis type 2 genetic disorder. There is no consistent sex predisposition observed in our veterinary companions, nor any genetic or hereditary predisposition. However, breed predilection also seems to vary a lot from one study to another, which it probably depends a lot to some degree on the differences in popularity of breeds geographically. But boxers and retrievers do definitely often appear on the predisposition list in the veterinary studies. Right, diagnosis. In many cases, the diagnosis in veterinary medicine is a presumptive diagnosis in cats and dogs. The morbidity and risk of surgical intervention, as well as the added cost towards treatment, can be significant depending on the circumstances. And as such, many owners do elect to treat without a definitive diagnosis, particularly if it is thought to not change the overall outcome. Whereas in humans, A definitive diagnosis is almost always provided on histopathology, which certainly gives rise to more reliable data when investigating tumor behavior and outcome. And due to its superior detail on the CNS tissue, MRI is a diagnostic tool of choice for the initial diagnosis of brain tumors overall. On imaging, meningiomas appear typically as broad-based masses, intimately opposing the dura, and often but not always associated with a dural tail. The tumor borders are usually very well circumscribed, and they most often take a rounded multilobulated shape compressing into the CNS parenchyma in approximately 70 to 80% of the time. They also can take a plaque-like shape, particularly along the skull base, but this is much less often seen. This is a very interesting phenomenon, the calvarial hyperostosis that we see right down right here. Is actually a very commonly seen phenomenon in cats with about 73% incidence. Only 25% incidence rate is observed in dogs, and a very variable range reported in humans between 4.5 to 44%. Hyperostosis is evident on both CT and MRI and is not always consistent with dural or bone infiltration of disease, but since pathology studies have identified bone invasion in many cases, margins around the extremity of these lesions is recommended in a surgical therapeutic approach in humans, and it is recommended to achieve a good 2 centimeter margins away from the edge of this hyperostosis in all directions. Therefore, this is a very important feature to note for appropriate surgical planning. Meningiomas will often present with a cystic appearance, and this is particularly true in dogs. And some of these cysts can be quite large, further contributing to compression of the surrounding parenchyma. One feature that is most striking in cats is the size of the tumor, as these grow so slowly, allowing the patient to gradually adapt to the environmental change. By the time the symptoms are well recognized by the owners, these tumors can be quite large, therefore often lead to a very high incidence of brain herniation. In one study, they found that all cats showed evidence of at least one type of herniation, 86% of them showing more than one concomitant type of herniation, and 75% showing 3 types of herniation at a time. In dogs, 67% showed evidence of brain herniation, but only 17% of them showed more than one type. And the majority of the dogs with herniation had subfalcine herniation, which is the least life-threatening type. Also contributing to herniation is the presence of parenchymal edema. 94% of dogs present with a significant amount of parenchymal edema, 43% of which tends to be limited to just the peritumoral border, and close to 60% of dogs will have edema extending deeper into the parenchyma. In one study, 70 to 80% of cats and dogs diagnosed with meningiomas demonstrated peritumoral edema. And in human, the incidence tends to be around 67%. So very common clinical change that we can see. Although T1 weighted and T2 weighted intensity signals from the tumor tissue is not 100% consistent in all cases, meningiomas do have the tendency of being iso to hypointense on T1 weighted images, and most often heterogeneously hyperintense on T2 weighted images. However, this can vary quite a lot. All meningiomas tend to be very contrast enhancing, and many show a remarkable uptake on both CT and MRI with a variable homo to heterogeneous uptake distribution. Interestingly, the distribution pattern and uptake extent can differ between CT and MRI, and this is very important to note so that both CT and MRI modalities are used for tumor contouring when considering the radiation therapy planning. The most common location in all species, I have that in the next here, is the rostro and supratentorial region of the brain, with a lower incidence of the caudo-infra or infratentorial region, depending if you're looking at the veterinary or human literature. And interestingly, only one feline study showed 17% of meningiomas were located in the third ventricle. This is not always reported to be as high, and it is much lower in most of the other feline studies. In humans, the incidence of intraventricular meningiomas has been reported also to be fairly low, only 3%. So this is these are just pictures of the same cat showing an example of the hyperestosis. This is a CT scan. And basically located in the cerebral convexity, which is also one of the most common location for meningiomas. And again, CT scan in the soft tissue window, showing that there is a significant uptake of contrast. And this is a cat that actually has two meningiomas at the same time. And this cat, as his response to radiation was actually quite different for both. This one did not really change in size, whereas this one did, in fact, change in size on follow-up imaging. This is the exact same slice showing that on the T1 weighted images, their tumors do tend to be hypo-intense. And then this is a T2 weighted image that is also showing the tendency of being hyperintense, which is true for both. Again, same slice here. This is the contrast enhance image, which basically shows also that there is a double occurrence. And you can also see that the hyperestosis is quite visible on the on the MRI images as well. And this is basically a sagittal view, which is also showing you the herniation here at the foramen magnum site. And I think I forgot to mention here, you also see a different type of herniation, which is a falcine herniation. All right, treatment options. So surgery, again, based on the predominant benign nature of these tumors in humans and feline, the surgery treatment is usually the treatment of choice, with the intent of complete removal whenever possible. And it does lead to a rather good prognosis in both of these species. Approximately 80% of meningiomas do recur in cats, and 80% of human patients that are diagnosed with meningiomas will still be tumor-free 10 years post-treatment. For this reason, only a minimal, small amount of these patients may ever require additional future treatments. Change it here, sorry. Although surgery also plays an important role in the control of canine meningiomas, because of the much higher percentage of invasive grade 2 tumors in the species, the recurrence rate is much higher and associated with a much shorter medium survival time. However, the surgical approach has been shown to have a significant impact on overall survival time, which should be taken into account when counseling owners with treatment options for these dogs. In one study, the rostro-supratentorial surgical approach was associated with a median survival time 3 times longer than the transfrontal approach. And so the surgical approach should also be taken into account when discussing prognosis with these patients. And also the use of ultrasonic aspirator has been shown to improve survival time. This is done usually by increasing the chance of achieving a more complete resection, and also by decreasing potential damage to the adjacent brain tissue and blood vessels, thus hopefully reducing the post-op complication and risk of mortality post-operatively. Only one study, unfortunately, is available in the veterinary literature regarding this technology, and which assesses only a small number of dogs, 16 dogs, In this evaluation, the ultrasonic technology resulted to a significantly increased median survival time of 1,254 days, which is approaching a similar survival time as seen in our feline population. Unfortunately, this is such a very small sample and therefore difficult to draw any reliable conclusions. However, this new technology has shown great promise in neurosurgery on the human medicine side as well as other surgical specialties, and this definitely warrants future investigation in our veterinary patients. Radiation for this tumor mostly plays an important role as an adjuvant treatment of incompletely removed tumors, or more importantly, for the treatment of non-surgical or high-risk tumor locations, such as the base of the skull. The veterinary literature regarding treatment response based on tumor behavior is clearly lacking, since in our patients, pre-radiation biopsies are almost never performed if radiation alone is being pursued, so that makes it very difficult to make that correlation. Unfortunately, data regarding radiation for feline meningioma is not really available, since most patients that do get radiation have not gotten surgery. There is only one case study, to my knowledge, that describes the response rate of meningiomas to stereotactic radiation therapy in cats. This case only involved 14 cats with an estimated median survival time of 11 months, but with also more than 50% of patients still alive at the time of investigation. In practice, because of this, discussion with owners regarding treatment expectations are therefore often extrapolated from the canine literature and also mostly experience. And we can see here the follow-up radiation is typically recommended when complete surgical resection cannot be achieved in dogs. And so this is so in humans as well. A few studies do support the use of radiation as an adjuvant treatment, with results suggestive of a possible longer achievable survival time in patients treated with both as compared to surgery alone. However, some facilities have explored the idea of radiation alone in the place of surgery for canine patients based on some comparative studies that were not able to demonstrate a superior survival in dogs when surgery was performed prior to radiation. Because of the limited tumor control time reported in dogs, many owners will elect to decline surgery, and as a result, radiation therapy has become more and more of a frequently pursued treatment as a sole treatment in dogs. When the introduction of stereotactic radiation therapy technology in veterinary patients, a few case studies regarding the use of this technology for the treatment of meningiomas have been published. The fewer visits and minimal early side effects associated with this technology allows clearly more convenience to the owner, as well as, of course, to the dog, and has become a very attractive option. Only a small number of dogs were included in the evaluation of response achieved with a CyberKnife, but this study definitely demonstrated a markedly superior median survival time. Early studies do report a considerable percentage of peri-tumor decline, decline with the LINAC-based stereotactic radiation, which was reported in all patients within a 6-month period in one study, which also included 3 fatal events, and at a rate of 37% in another stereotactic study that included a mix of protocol ranging from 3 to 5 total fractions. The most recent study evaluating stereotactic treatment, which is the CyberKnife study, did not report any adverse effects. And this may partially be due to the improved planning skills and knowledge of recommended dose constraints that have developed in veterinary medicine during the years following the introduction of this newer technology. More careful selection of our patients considered to be good candidates for hypofractionated stereotactic treatment has no doubt improved this high percentage of complications. And one important factor needed to be taken into consideration that we are far more aware of today is the overall size of the treatment of the tumor. So in conclusion, the challenging cases in our veterinary world come mostly from our canine population, which we are assuming are more often classified in the atypical grade 2 and a few in the grade 3 category. These two grades are associated with a much higher recurrence rate in humans, 41% as opposed to 75% for the grade 3 respectively. Unfortunately, most of the canine literature tends to list the subtypes included in the study data, but not the grades. Therefore, a breakdown of recurrence rate between grade 1, 2, and 3 in canines is really unknown. Radiation therapy is the next treatment of choice in patients whose tumors are deemed non-surgical. Reported survival times vary significantly in our literature, partially due to the many small sample size and likely due to the wide variation of grades in the samples from one study to the next. And since the percentage of grade 1 and 2 in the canine population is thought to be about 50-50, response to treatment may be greatly impacted. Without postmortem follow-up or pre-treatment biopsies, such data cannot be collected and the expected outcome remains unknown. So with the new grading system, focusing more on the mitotic rate, pathologic tissue pattern, and cellular features, hopefully we can start collecting more informative data to help better predict the expected behavior between these grades in dogs. It would also be interesting to further investigate to see the correlation between the treatment grades outcome as well in our canine patients. Because there is no documentation stating if the progression-free survival is longer for grade 1 than grade 2 tumors in dogs, it is difficult to guide our clients to in the right direction. And if progression-free intervals are longer for canine with grade 1 tumors with surgery alone, then perhaps grade 1 patients would benefit more from surgery alone than radiation. And maybe radiation should be reserved for treating these patients only if and when recurrence develops. If grade 1 tumors do take longer to recur, then this approach could potentially increase the overall survival time in low-grade canine meningiomas and also delay any potential radiation-induced side effects. However, to make this determination, brain biopsies will first be necessary in order to confirm the diagnosis and make the more appropriate decision between surgery and radiation. All right. Let's now turn to our dear Dr. Beal, who will surely enlighten us all with new exciting treatments on the horizon regarding boosting the immune response to the brain. Afterwards, I would be very happy to take any questions.
Thank you so much. Can you see my appropriate presentation slides? Yes. Okay, great. Rachel, I really enjoyed your talk. First of all, are you from Washington State?
No, I am not.
I
am a Canadian from Manitoba.
Oh, I see. Okay, I noticed you went to maybe college or veterinary school in Washington State. I'm from Seattle originally.
Oh, yes, I did my internship there.
Ah, right. Okay. Well, anyway, so very interesting talk. I'm a human radiation oncologist, and I'm going to speak on a little bit of a different subject with only human data involved, but I think the concepts of how to boost the immune system, or the fact that there really even is an immune system in the brain, should be applicable to veterinary patients as well. And actually, I really appreciated your wonderful anatomic description of the meninges, because it absolutely demonstrated the intimal network and relationship of blood vessels to the brain parenchyma underlying. And clearly there is a relationship, obviously, of the lymphoid system that's innate with the blood vessels, and there's got to be some ability for the lymphoid system or the immune system to get into the brain, even though we think of it as a sanctuary site. So I sort of hope to elucidate that concept today. Again, I realize we're getting a little pressed on time, so I might jump through some of my slides so we have plenty of time for questions and answers at the end. Okay, so I'm going to try to just show some evidence that brain radiation and the immune system work synergistically. I'm going to speak more about radiation than surgical options. I'll also show you that radiation necrosis, which basically shows sort of a very reactive process to high dose radiation, actually portends a good outcome. It sort of shows that we are eliciting an immune response. And also corticosteroid avoidance can improve outcomes in some of our patients, human patients. I noticed, Rachel, in your data, you talk a lot about the edema associated with dogs in particular that have a higher grade meningiomas. And I think you said 80 to 90% of meningiomas in dogs have tumor associated edema. So I was curious about how you might use corticosteroids or not in your patients. And then I hope to prove that brain radiation and the immune response or synergy can be optimized, and minimizing use of corticosteroids is important for patient health. Also, hypofractionated radiation is more immunogenic than fractionated radiation, which you probably don't use a lot in animals. And if we have time, I might talk about metabolic manipulation as well, but might run out of time there. So more than 10 years ago, we started to really understand, I'm not quite sure in animals how many animals develop cancers that spread to the brain, but there are in humans, many different subtypes of cancers that spread to the brain. And we started to notice that some patients with brain metastases were performing better or living longer than other types of patients. And it seems sort of obvious now, but a little more than 10 years ago, this is a real breakthrough when we started noticing, for instance, in breast cancer, that a certain subtype, patients who have HER2 amplified breast cancer, for which we have a very good targeted drug, those patients started to live longer on a survival curve. You can see this green curve. These patients who had HER2 amplification were living longer than those who did not have HER2 amplification following stereotactic radiosurgery for their brain metastases. In addition, at that time, we started looking at the absolute lymphocyte count. So looking at how robust a patient's immune system was, and that was independently predictive of outcomes. So patients who had a normal ALC of 700 or higher per microliter had actually better outcome than those who had a weaker immune system, essentially. And when you put those two things together, the HER2 amplification, the ALC, without a doubt, those patients were surviving longer. So this was sort of our first hint that it actually mattered for survival and our outcome in patients, that a healthy and robust immune system, even with a brain tumor, was important. Then a couple of years later, we started using checkpoint inhibitors with patients with melanoma and combining that with stereotactic radiosurgery, so really high dose immunogenic radiation. And we started seeing very good results in some of these patients. Do you use checkpoint inhibitors in cancers in dogs or cats or any animals? No. So no. Okay. So checkpoint inhibitors, for those of you who don't know in the audience, are drugs that basically take the brake off your immune system. So if you give a big dose of radiation, that is in some sense like a vaccination. You are interrupting not only the tumor, but also the microenvironment around it. And then if you add what we call a checkpoint inhibitor, a drug like ipilimumab, you take the brake off of your immune system. Everyone, animals, humans, all species have a check and balance with their immune system. So I'm sure all species have some tendency to develop an autoimmune disorder when their immune system's revved up too high. So that means their brake system's not in play. And many cancers in all species are also independently controlled by the immune system. And sometimes if we give the immune system a little boost by giving drugs called checkpoint inhibitors, so releasing the immune system, we can get a better response. And melanoma is a classic example of that. I doubt animals get melanomas, but this is our first type of cancer where we really showed that this combination of a checkpoint inhibitor and high dose radiation was changing the outcome in patients. And one thing that we saw is when we combined high dose radiation, so stereotactic radiosurgery, like you might do with CyberKnife for your veterinary patients, and we combine it with a checkpoint inhibitor, we were seeing this heightened immune response in the brain. And what do I mean by that? So if this curve here shows you at time 0 on the x-axis, and the relative size of the tumor is 1 on the y-axis. When that is the time 0 is when you treat the patient or the tumor with stereotactic, so the high dose radiation like you're giving your veterinary patients. And interestingly, typically tumors shrink as Dr. St-Vincent showed us. But when you give this checkpoint inhibitor, which the time point is indicated in the black boxes, these tumors actually grew dramatically. And so, tumors weren't obviously truly growing through this therapy, but they were larger in size. So we thought to ourselves, well, what is this response? And it actually reflected an immune response right in the middle of the tumor in the brain. So again, this sort of real evidence that we're seeing an immune response in the brain. And in fact, we took a number of these patients, human patients, to operating room and removed these tumors because we didn't quite understand what was happening, and found just pure reactive radiation. What wasn't classic radiation necrosis, just cystic lymphatic response, demonstrating this immunogenic response in the brain. And here's an example of a patient who had a very tiny brain tumor. You can see pre-treatment in the left panel on the MRI. You see that very small tumor. Can you see I'm circling it with my cursor here? Yes. Okay, so this was pre-radiation. This is a tiny tumor. You would expect this just to melt away with stereotactic radiosurgery, CyberKnife or otherwise. And we treated this with concurrent ipilimumab, that's that checkpoint inhibitor I was describing. 6 months later, you see this, large growth in the size of this tumor, but it's not active tumor. And I know that from, experience in advanced imaging. And this patient had asymptomatic classic radiation necrosis. And this is a very robust response to radiation. And we decided to observe this patient, and the radiation necrosis spontaneously resolved. And 10 years later, this patient remains cured of his melanoma to his brain. This is shocking. Most patients, human patients who have melanoma to brain, pre-immunotherapy checkpoint inhibitor era, died within 3 to 4 months. So this is just incredible sort of advance in our ability to treat patients. And again, this is a combination of revving up the immune system with radiation and a checkpoint inhibitor. I'm going to jump through a couple of these slides, but we took a look at some of our human patients with very long survival following melanoma to brain, which again used to be a death sentence. And we found a very high rate of radiation necrosis. So this high reactivity. So the patients who did best, who survived more than 5 years after having melanoma brain metastases, were those who had radiation necrosis, were much more likely to have radiation necrosis than standard population. About 50% of them, of the tumors we treated, had radiographic radiation necrosis, and 25%, we actually took those out and found pure radiation necrosis in the operating room. Typically, radiation necrosis rates are under 10% for all tumors treated. So these are very high rates, but it corresponds with a heightened immune response actually in the brain, which is what I'm trying to prove today, that this response is important. Other groups have also demonstrated that following stereotactic radiosurgery with melanoma, if you develop radiation necrosis, so patients who develop radiation necrosis in the blue have better survival than those who don't. That's the survival curve here in the red. Likewise, in other types of tumors that spread to the brain, so not just melanoma, any type of tumor spread to the brain, when you treat them with stereotactic radiosurgery, if they develop radiation necrosis, again, this blue line, they have a better survival probability than the patients who do not develop radiation necrosis. So separate groups, not just melanoma groups, have shown or concluded that the process of radiation necrosis is immune mediated. And so it's possible that patients who develop radiation necrosis are more sensitive to radiation therapy and systemic treatment. So they've got this heightened immune response, which we think is actually controlling the cancer in the brain, likely elsewhere in their body. This is a patient example, a human patient example of a kidney cancer spread to the brain. This patient came in very symptomatic and required high-dose corticosteroids. At this point, when I treated him, I knew corticosteroids had a much deeper understanding that they are very immunosuppressive. So we took him actually off the corticosteroids, even though you can appreciate a lot of edema in his brain, and instead put him on a drug called cabozantinib, which is a VEGF inhibitor. Probably not something used in veterinary medicine, but it's a good substitute for a corticosteroid because it also reduces peritumoral cerebral edema very effectively. In fact, might be something interesting for you to think about for your dogs in particular with meningiomas, with all the edema they have. He was treated with a concurrent checkpoint inhibitor called nivolumab and stereotactic radiosurgery, and remarkably had a complete response to his treatment of that combination, and he remains without any evidence of disease after having 7 truly deadly brain metastases. So again, this combination of sort of supporting and revving up the immune system with radiation seems to be very useful in certain subsets of our human patients. I am going to, let's see, what's the time here? Skip ahead on this slide, but I will just suffice it to say that we have similar, dogs, I don't know about cats, but I believe dogs get gliomas and glioblastomas or high-grade gliomas. We have found similarly in humans that similar to other types of tumors, that if you give high-dose radiation, which is again more immunogenic than what we call fractionated low-dose radiation over 6 weeks, we're getting a better immune response. And again, if we can avoid steroids and give bevacizumab instead of steroids, instead of corticosteroids, we are getting a better result. So a cohort of patients treated with high-dose hypofractionated radiation therapy, bevacizumab and Tembenar, in the patients in whom we avoided steroids, this is the black line, they had a better survival than the patients who had steroids. And these are the exact same group of patients controlled for only by steroids. So again, steroids are immunosuppressive and somehow are leading to, we believe, inferior results. So why does that happen? There is a neurosurgeon who was very interested in this concept across the street at MSKCC, and I provided some of the clinical data and worked with his fellow to take a look at this concept. And when we looked at 3 different cohorts of patients at MSKCC, Memorial Sloan Kettering Cancer Center, the ERTC, which is a big human network database of patients, and then the German Glioma Network, 3 separate cohorts of patients with high-grade gliomas, and looked at the outcomes for survival based on use of steroids or not. Steroids in red, bad, had worse outcomes than the patients who did not have steroids here in black. And so if you think about why is that, again, I've given this concept that corticosteroids can compromise survival because they are immunosuppressive. And we developed some mouse models actually to look at that, and looked at different dosing of radiation with or without steroids. And again, consistently showed that when steroids were on board, we had worse outcomes in these mice. And then finally, we also did a genomic analysis. So looked at the TCGA, which is the large network of the Cancer Genome Atlas. So thousands of patients' genomic data. including patients with glioblastomas, and showed that dexamethasone treated glioblastoma cells that are removed in the operating room, and then we submit them to this database and do genomic analysis on them. The patient's tumors that were treated with dexamethasone or corticosteroid had downregulation of their cell cycle genes. And if their cell cycle genes or their cell cycling is downregulated, that actually means they're going to be less sensitive to radiation. Tumors that are more rapidly dividing, actually almost counterintuitively, are more sensitive to cytotoxic therapies like chemotherapy or radiation. So last thing I will mention here in the interest of time is that we've also noticed that radiation induces an upregulation of a protein or an enzyme called fatty acid synthetase. And so when you treat a cancer cell with radiation, you get these, well, specifically a glioma cell, you get an upregulation of FASN, and with that, an upregulation of lipid droplets within the cell. And these lipid droplets are kind of like a little power or like energy bar that the cell holds on to as it's under stress. So as the blood supply is being removed and oxygen is being removed, these lipid droplets are a way for it to protect itself, so it has some spare energy so it can stay alive. And another thing that these lipid droplets do is, so again, radiation upregulates FASN, and with that you get an upregulation of intracellular fatty acid pool, and then actually fatty acid oxidation and a downregulation of many types of the extracellular matrix surrounding immune cells. So a downregulation of the immune system surrounding. So it's very protective of the cell to do this. So we came up with a hypothesis that blocking FASN might restore the sensitivity of irradiated GBM cells to the immune checkpoint blockade. I hope I've shown you some examples of why the immune system is so important in regulating the brain and brain tumor health and helping our patients, survive their whatever type of tumor they may have. Thank you so much.
All right, thank you both, Dr. St-Vincent and Dr. Beal. We've got some questions coming in. One question, it looks like it's for Dr. Beal. It's when melanoma brain metastases treated with SRT and ipilimumab increase in size, but it's actually necrosis, is this considered tumor pseudoprogression?
Great question. It is. So if you look at follow-up MRIs of patients treated with stereotactic radiosurgery alone or stereotactic radiosurgery with a checkpoint inhibitor like ipilimumab, we do see a difference in the sort of radiographic response, and this concept of pseudoprogression is much more common. There are ways with sort of advanced imaging to distinguish this. I'm not sure if it's something you see in animals or not, but I suspect over time this, as we evolve our cancer therapies, that again for all species, this will become more of a concept with other types of cancers and diseases as well.
Perfect. That's the only question I see popping up at the moment. I see some comments on here. Any other questions that anybody may have?
I have a question for Dr. St-Vincent.
Oh, okay, yeah.
So I thought it was so curious that dogs have, I think you said, about a 50% grade 2 rate of grade 2 or 3. Humans, about 85% of meningiomas are grade 1 and about 10% grade 2 and less than 5% grade 3. And I was wondering if you had any sort of theories about why that is. It makes sense that they're going to have more edema, but like, why would the dogs have such a more aggressive phenotype of a tumor?
That's a good question. I don't know if I have a good theory. I think what's been most frustrating with our ability to know exactly what we're treating is, these are all assessment usually done on post-mortem, but when we are actually treating and following up our patients, majority of the time we don't know what grade these tumors are in. And if you pull all these canine studies, you will notice that they often list all the subtypes. And then at the end of the article is like, well, what does that mean? And many articles have pointed out that there really is no correlation between the subtype and the outcome, but they don't mention the grade. I remember following up on one study where they actually wrote down the grade, but they did not comment on did that correlate with the outcome. They just mentioned the grade, which I was all exciting as I was reading the article. I'm like, oh, here's one that might actually show, the correlation, but they really didn't bring that up. I think where we're at, we have a new updated grading system, which is fantastic, but it's only come out. It's only been published in 2023, pretty much at the end, around December is when I think that article came out. And what I think we need to start doing is actually grading these tumors and not just listing out what subtype they are, because clearly, based on what we know, it doesn't really matter what subtype they're in. It doesn't seem to make a difference as far as how they're likely going to respond to treatment. And so I think we have to start there first. Is knowing we have now a new grading system, what is that percentage going to be? Is it going to change? Are we going to have more patients now in the grade 1 or not? And then again, because we're very limited with how well we can achieve complete removal of tumors surgically, we may be leaving more disease behind easily, because these tumors do tend to be, even though they're not necessarily atypical, even the grade 1 tumors that have been confirmed grade 1 tend to have a little bit of they're adhered to the brain. So unlike in the cats, when we do surgery on the cats and you take that skull off, the tumor is attached to the skull.
Right.
They're not really adhered, so they come out almost clean on their own, and oftentimes don't really require significant dissection, whereas with the dogs, we tend to see that more often, even in the tumors that are graded grade 1. So again, I'm not really sure what to think about that, but I think that has a lot to do with the reason why we have more recurrence. And that ultrasonic aspirator technique, which in that one study, although it was a very small number of dogs, did show a significant improvement in survival time that pretty much is almost what we're achieving in cats with surgery. And so it'd be really interesting to know, if we all started to use that technique, would we improve the amount of disease we're removing? And perhaps we would get a much better survival time if we can also grade these tumors and get a better idea of how does behavior correlate with success rate. And of course, my big question is, well, because a few studies have shown that there's no significant increased survival time between dogs that are treated with surgery and radiation versus just radiation alone, we're seeing now more and more dogs just coming in for radiation. And I guess my question is, well, if we had a better surgical technique and they were graded grade 1, because I don't necessarily treat all cats that, well, maybe we don't have clean margins, maybe we do. Usually, if a cat gets surgery, it goes home and that's it. And most of them live 3 years on. My question is, these are such slow-growing tumors. They are in geriatric patients. Even if we do have a little bit of disease left behind, if they are grade 1, would we not be better off to let nature take its course, monitor with imaging, and only treat when we start to see recurrence? Because if there's just a little bit of tissue, these dogs come out already clinically improved. It may take 2 years before that tumor really becomes clinical.
Yeah, that's what we do with humans.
Yeah, and because our patients are mostly geriatric, in the 10-year-old dog, that could mean, well, it's not really going to become a problem again until 2 years, which in that case, he's kind of almost achieved, his survival expectations. If he's really in good healthy condition, we have the option of maybe doing another surgery, or at that point, yes, consider radiation.
And the benefit of that is, well, we don't have to worry about any kind of radiation-induced side effects for at least 2 years before we feel that we need to take that approach. And that's more of the approach we take with cats. So, you know, my feeling is we first need to get a better sense of, is this grading system going to be helpful in determining outcome in our dogs? And will that percentage between grade 1, 2, and 3 change now that we've changed the grading system? And then once we get more of that data, we can then also start looking. And, you know, maybe we need to discuss, perhaps we're not taking the right approach in our canine patients. But as far as, you know, predicting why in dogs we see more atypical than in cats, I'm not really sure.
Excellent. We've got a couple other questions, which I believe both are for Dr. Beal. One of these questions looks like it has 3 parts. It is, what is the patient's quality of life during the boosting of the immune system? Is this precision cancer care? Wouldn't less be more with precision treatments?
Well, I would think that's maybe more directed towards me. So with boosting the immune system, yeah, the checkpoint inhibitors can certainly have a lot of side effects, not for all patients, but for some. And but on the other hand, for the cancers that it's approved and proven in, it's life-saving. You know, so without a checkpoint inhibitor, for instance, metastatic melanoma, it's incurable. So yes, there's a careful balance with that. But what I was hoping to also demonstrate is that outside of checkpoint inhibitors, corticosteroids we have a much better understanding that they are immunosuppressive, and I am quite confident, and we've shown this in animals as well, that corticosteroids are immunosuppressive, and if we can avoid or reduce the requirement of corticosteroids for our patients with brain tumors, we are seeing better outcomes. So anything we can do to support the immune system, and that may be withholding, you know, corticosteroids or using an alternative, for instance, like a VEGF inhibitor, or another type of drug that reduces cerebral edema, or maybe a technique with surgery instead of radiation, that may be something that will benefit all types of patients. Precision medicine is, when we use that term, at least in humans, typically that would indicate treating a type of cancer that has a single mutation driver. I'm not sure how often that happens in animals, but in humans, for instance, a classic example of that is a lung cancer driven by an EGFR mutation. And if patients have that relatively simple single gene driver, we can give them a drug. The latest one is one called osimertinib. There have been many different ones along the way, but that's the most contemporary drug. And you get incredible response throughout the body, including the brain. And we don't need to use steroids. We don't need to use checkpoint inhibitors. And it's a very effective form of treatment. So it's a balance. It depends on what type of tumor you're treating.
All right, another question is, I believe also for Dr. Beal, any clinical signs with RN in human patients treated with brain metastases from melanoma?
Sorry, any what?
Brain mets.
Right. But I'm sorry, what was the preceding part about the brain mets?
Any clinical signs with RN in human patients treated with brain mets from melanoma?
Oh, any clinical signs for radiation necrosis? I see. All right. Yeah. You know, actually, sometimes it's asymptomatic. I'd say without a checkpoint inhibitor on board, we say roughly 10% of brain metastases treated with stereotactic radiosurgery develop radiation necrosis, dose and size dependent. With a checkpoint inhibitor given, it's probably much closer to about 25 or more percent. However, in either group, roughly half the time, the patients are asymptomatic. So that example I gave, the patient was asymptomatic and had a pretty robust case of radiation necrosis, a tiny little tumor treated with stereotactic radiosurgery and a checkpoint inhibitor, and then, you know, several centimeters of radiation necrosis processed with surrounding edema. He was asymptomatic. I didn't put him on steroids. We just observed him very closely. He didn't have a seizure. He didn't have headaches. It depends very much on the location in the brain for an animal or a human alike. And if they do have symptoms and it's a seizure or some local symptoms, we will treat with antiepileptics or steroids or surgery occasionally. But there's not sort of one clinical sign to look for.
All right, one other question for Dr. Beal. In patients with a lot of edema with herniation risk, do you worry about overboosting the immune response? If we treat with VEGF inhibitors prior to treatment, will VEGF inhibitors stabilize these patients as quickly as corticosteroids?
Oh, such a good question. Yeah, we definitely worry about that. If there's a real risk of herniation, I get neurosurgery involved, as I'm sure you would do for animal patients as well. And only rarely with a checkpoint inhibitor do you see a really robust direct immune response throughout the brain that could put somebody, you know, in a very precarious or life-threatening situation. Typically, if you're treating with stereotactic radiosurgery, you just get surrounding local edema, and patients, if they are going to become symptomatic, get symptomatic not dramatically overnight, but sort of subtly over days to weeks. And so we can anticipate that and treat them with corticosteroids. But yes, one of my favorite ways to treat patients, if it's available, is with VEGF inhibitors. And in fact, I have a number of publications and studies I was involved with using bevacizumab with high dose radiation for gliomas, for glioblastomas. And again, that was one of the slides I shared. Those patients in whom we treated that way and avoided steroids had better outcomes than the patients than when we added steroids in.
Excellent. Thank you both so much. It looks like those are the only questions that we have popping up. So thank you all for joining us tonight. Please click the link in the chat box or scan the QR code to submit your CE credit request. Certificates of attendance will go out on Wednesday, November 20th. Tomorrow's topic will cover breast cancer, and we will be joined by Dr. Larry Norton and Dr. Nicole Liebman. We hope to see you there.